mode.
Okay, welcome everyone. I'm Megan Zottarelli, your facilitator for today's webinar on aging veterans. This webinar is organized by the Institute for Veteran Policy at Swords to Plowshares as part of our Veterans and Behavioral Health series to discuss health outcomes and considerations for care of aging veterans from a community perspective. As veterans get older, they may exhibit military-related primary and mental health issues in concert with typical age-related stressors, such as retirement, bereavement, and physical decline. Research shows older veterans are predisposed and have early onset for a variety of health issues impacted by their military service. And while Vietnam veterans age, we must prepare to treat a host of issues associated with the neglect and lack of services they've received. During this webinar, 2 continuing education units are available for MFT, LPCC, LEP, and LCSW professionals licensed in California. Certificates of completion are also available. During this webinar, you may type a question to the panelists or to Swords to Plowshares staff at any time. Simply type your questions in the questions box on the right side of this webinar's display. At the end of the presentations, we will review the questions and comments posted and generate a discussion. Please note that this webinar is being recorded and will be archived on the Swords to Plowshares YouTube channel. You will receive a copy of the PowerPoint by email following the presentation, as well as an evaluation where you can rate today's webinar, which is essential for receiving your continuing education units. So our first presenter, Amy Fairweather, Director for the Institute for Veteran Policy at Swords to Plowshares, will cover the demographics of aging veterans and health outcomes related to military service. Michael Blecker, Executive Director at Swords to Plowshares, will cover the Vietnam veteran generation and the legacy of neglect. Finally, Janice, Geriatric Specialist at Swords, will cover housing and clinical outcomes of aging veterans from a community perspective. So our first panelist, Amy Fairweather, directs Swords to Plowshares Institute for Veteran Policy, which conducts public policy regarding and research regarding veterans' health, access to benefits, and socioeconomic well-being. She has worked in the field of public health policy, in particular with and for trauma survivors, since 1999. She received her undergraduate degree from Mills College and her Juris Doctor from Hastings College of the Law. Amy is a member of the State Bar of California. Welcome, Amy.
Thank you, Megan. Am I unmuted? Okay. Thank you, Megan. So first I will, what's going on? I'm seeing the, hold on, I'm just trying to fix my slides here for a minute. I'm sorry about that delay. So I'm going to start off by interviewing an overview of services here at Swords to Plowshares. Swords to Plowshares is in the San Francisco Bay Area. Began in 1974. We offer a broad array of services as a community-based nonprofit provider for veterans. We have 7 housing sites, which include permanent supportive transitional housing, and permanent supportive housing. In addition, we have our employment and training unit, which works directly with veterans to assist them in getting employment and works with employers to develop trainings that are appropriate to get veterans up to speed and on board for good jobs and careers. The Institute for Veteran Policy, which is the department that is presenting this webinar, works on veteran policy. We also engage in research and presentations. Just a plug coming up, we're going to have a moral injury full day in-person event at USF. You can check our website if you're interested in coming to that. In addition, we have health and social services. We have a drop-in center where veterans can come in and get help with their needs, get triaged to the other programs within our organization, or directed to community-based care or VA care. Our Women's Veteran Program is growing. We're very excited about it. And it includes the Women Veteran Professional Network, which is assisting women in providing mentors and working with them who are, whether they're underemployed or unemployed, to develop those supports and secure meaningful employment. Our legal services for veterans with disabilities is all around VA claims and discharge review. So they help veterans get through what can be a very daunting process of becoming service-connected and gaining access to services and supports. So as we get into what we're talking about today, aging veteran demographics, as you can see, a substantial majority of the veterans in our country are over 55. They are not getting younger. No one's getting any younger, and we really need to look at this information and prepare for those needs and make sure that we can quickly address the medical, mental health, as well as housing and other supports that our aging veterans need now, and also in the future as they get older and need more supports. I'd also like to point out that this is veterans age 55 and over, and while we really are looking at the Vietnam era generation during this presentation, some of our younger vets are going to be 55 fairly soon. The Iraq and Afghanistan wars started 13, 14 years ago, so it will also do us well to prepare as all of our veterans age. So one of the first conditions that we're going to talk about, and I do want to stress that I'm not a clinician, I'm presenting this for informational purposes, is loss, which is distinct from PTSD, late onset stress symptomatology. It's sort of related to PTSD in the sense that reminisces memories and the stress that it creates decades after combat that one has experienced in early adulthood. So this has a significant impact on well-being, and again, without being a clinician, when we look at the rates of depression and suicide, this is no doubt linked and correlated with those issues. Post-traumatic stress disorder, which we are familiar with. It's important to understand that it is post-traumatic stress disorder, so after the fact. And while we always encourage people to get early treatment intervention, that does not mean that PTSD will not or cannot last throughout the lifetime and in fact worsen in later life. So we see here that many older veterans 50 or more years after the wartime experience are experiencing the stresses related to PTSD. 30% a lifetime prevalence. So again, we have to make sure that we have the facilities for these veterans, whether they be residential facilities, people are experienced with the cultural issues that face veterans, with the specific disorders that veterans face, and are able to provide culturally competent care. Now, while we're familiar with PTSD in terms of its impact on mental health, it's also associated with much higher rates of medical conditions in veterans. It's not really surprising when we look at the stress and the impact that stress has on the physical body, but Vietnam veterans with combat-related PTSD have more chronic health problems than those without, and are much more likely to have other poor general health. I'm not going to read out this list, but again, it's a broad range of physical and healthcare needs. And as we're going to discuss a little later, this of course has a huge impact on housing and provision of care for those veterans, and whether or not the people who are caring for them are aware of the connections to PTSD service, combat service, and whether or not there are appropriate services, supports, and the physical plant where these people are living is appropriate. Suicide. We've all heard the figures, 22 veterans a day. There's some question about how that data is put together, but we do know that there is significantly more suicide, and particularly among older veterans. So 2/3 of those who complete suicide are age 50 or older. This is, I think, maybe a surprise to some people. A lot of the news that has come up around suicide has been looking at our youngest generation of veterans. Of course, we want to prevent any suicide, no matter the age, but it's very important that we go back and make up for some of the lapses that we've had in our service systems and in our society to provide the social support that they are lacking and to respond to these suicidal ideation and the mental distress that our older veterans are experiencing. And to understand that this is not something that goes away. I want to tell a very, very quick story here. I was at the Vietnam Memorial in Washington, D.C. a few years back, and I was with a colleague of mine, and we were looking at the wall, which of course is, incredibly impactful. And there was a gentleman and his wife, and I would guess they were, late 50s, early 60s, and he was weeping. And the wife, or presumably his wife, I didn't know, was embarrassed and was saying to him, "It's been 40 years. Essentially, get over it." And it was so sad, and the idea of this gentleman who needed those supports and the misunderstanding that time would lessen the feelings that he was having. So again, it's important to be empathetic. Okay, PTSD and memory loss. Appears to be more prominent with people with PTSD and memory loss. We're going to get into more dementia and Alzheimer's a little later, but this is just memory loss. So aspects of memory, again, when we're thinking about the provision of services, whether or not they're easy to navigate, whether or not providers know what sort of needs their clients have, what kinds of appointments, what kind of medications. When we think about memory, this is something that we have to take a special look at. All right, and now we get to dementia. Again, early onset of cognitive impairment and twice as likely to develop dementia. Also twice as likely to develop dementia with no depression. Right now, and I know that people who are listening are not necessarily in California, I'm not as familiar with other states. In California, we really have to. Something just happened with the sound. There's someone else's mic is open. Okay, thank you. So again, I'm not sure what's happening in other states. In California, a lot of the homes that are administered by the California Department of Veterans Affairs are not necessarily prepared for this. They have stood up several new homes that do have memory floors and are dealing with Alzheimer's, but I think that more needs to be done in this area. And once again, my old refrain, we have to be prepared and meet the needs of these veterans. Also, traumatic brain injury and dementia. Now, traumatic brain injury has come up in the news, with the wars in Iraq and Afghanistan quite frequently, and is pointed to as a signature injury of the war. But it's no surprise that older veterans were also exposed to explosive force. Again, just very quickly with traumatic brain injury, there doesn't need to be a penetrating head trauma. It can be the concussive force alone of an explosion, which causes the brain to be damaged. It's not necessarily visible in any way. And also, I think now, because of the higher attention being brought to it, there are screenings for this. People are more aware of, and families are more aware of looking at changes in their veteran, looking at cognitive changes, or if there's a difference in behavior before and after service or before and after exposure to concussive force. That was not the case for Vietnam veterans. However, we do know that TBI existed then and still exists, and in fact has, once again, a higher rate of dementia. So 16 compared to 10%. It is also earlier onset. So hopefully we will start to screen older veterans for this and be able to provide them appropriate services as well. Alzheimer's disease. Once again, both PTSD and TBI show to be risk factors. Brain injury, however, is the earlier onset and acceleration. And there has been a study of World War II with moderate and severe head injury. And once again, we know that while this was not named TBI then, that it's definitely prevalent in all ages of the service. Another health outcome is a higher level of diabetes, quite a bit higher, 1 in 4 veterans compared to 1 in 10. Our next slide is going to look at some of the reasons why. Agent Orange, of course, the herbicides we know is connected with diabetes. That diabetes is a service-connected injury, and we will also talk a little bit about getting your older veteran service-connected for that. But there are other issues as well. The social disparities, lower incomes, limited access to healthy food. This is also going to connect a little bit with what Michael is going to talk about in terms of the people who served in Vietnam and the outcomes for them when they came home in terms of their incomes and their access to a healthy, high-quality life. We also see much higher rates of obesity in the VA patients, which of course is a risk factor for diabetes. A little bit more about Agent Orange. So I think, as we all know, it was an herbicide used in the Vietnam War. There was quite a struggle, and Michael will talk a little bit more about this, and getting these illnesses recognized and getting some sort of help for veterans. I'm not going to go through the very long and complicated list on the right of your screen of conditions and diseases associated with it, but you can see there are a lot of them, and there are things that the common layman nor a physician who is not familiar with veteran issues would necessarily connect with service. So it's important that those physicians know that. And if they're treating someone outside the veteran system of care and they're of a certain age and they have these issues, they should ask them. Actually, they should ask them outright whether or not they have the issues or not. Military, whether if they have been in the military, that can have a lot of impact on their health outcomes. And then when they see these issues come up, perhaps be able to know the resources available to the veterans, refer them to a VSO in their area that can help them get service connected for these issues. As we see in the lower left-hand corner, the VA now presumes that certain conditions are service connected. And what this means is they no longer have the burden of proof to show that they served, where they served. Well, they still have to show that they served, but they don't have to show when they were exposed to Agent Orange. They simply have to show that they served during that time period and that they have a condition which is considered a presumptive condition in order to get those benefits. We are seeing here at Swords to Plowshares a number of older veterans who are just now manifesting these conditions and who we are assisting in getting service connected. It's very important that both the disability benefits that the veterans can get, and in the case of the VA, some of the specific care related to exposure to Agent Orange, that because they have been serving this population for a long time, they have some of the best health care available for it. Now, I know that it can be an obstacle to get that care. So once again, it's important for these doctors and for the systems, for the providers like ourselves, to help those veterans navigate the systems, get to that care, to help them if they're having memory problems or dementia, to make sure that we are helping them to remember what sorts of appointments they have, what sorts of medications they have, and to really to shepherd them into the care that many of them have been denied over these many years. So moving on, homelessness. Once again, much higher prevalence of homeless veterans who are 51 or older, 19% of non-veterans. Now, we've known for quite some time that veterans are overrepresented as homeless compared to non-veterans overall. These are a very vulnerable cohort. Not only are they aging, are they veterans, often they have been chronically homeless. They have not had access to care or supports. They've been neglected. Michael's going to talk a little bit more about that. And therefore, they have more rapid disease course. They have health care needs that have been exacerbated, often comorbidities, substance abuse, and simply the hardships of being homeless. You know, not only the physical hardships, but the stress, and you put this all together, and we have an extremely vulnerable homeless population of older veterans. It adds to the challenge for providers, and Janice will be talking a little bit later more about the ins and outs and the day-to-day of providing care for these veterans. It also goes to the case that we've been working very hard, and we certainly are very gratified with some of the changes in the systems dealing with ending veteran homelessness, and certainly it has been reduced, and our own housing has increased because of some of these programs. But we know that we have challenges ahead of us. Now we're looking at this very, very vulnerable subsection, the most chronic homeless, the most vulnerable homeless. We do need more housing. We do need more 24/7 care. And we have to make sure that we have the systems in place to be able to respond to these needs. It truly is a very heavy burden on the men and women who work in these housing facilities, and we need to make sure that we have the money and the staff and the facilities and the will to not only get people off the street, but keep them off the street and make sure that they live in dignified housing and also have all the supports that they need. That is actually it for my slides. And now I'm going to turn it back to Megan, and Megan will introduce our next speaker. Thank you again for being here.
Thank you so much, Amy. Our next panelist is Michael Blecker, Executive Director of Swords to Plowshares. Michael has worked for Swords to Plowshares since 1976, only 2 years after its founding in 1974 by a group of Vietnam veterans and VISTA volunteers at the San Francisco VA. He is a co-founder of the California Association of Veteran Service Agencies, the National Association for Homeless Veterans, and a founder of the Coalition for Iraq and Afghanistan Veterans. Michael represented and won one of the first cases at the Board of Veteran Appeals for post-traumatic stress disorder compensation in 1979. Michael served in the U.S. Army from 1967 to 1970, with combat infantry service in Vietnam in 1968 and 69. Michael holds a Juris Doctor from New College of California School of Law and a bachelor's degree with honors from UC Berkeley. Welcome, Michael.
So today I'm going to talk to you about the Vietnam veteran generation. And as you can see in the slides, there's these three big issues about contributing factors to the situation with the Vietnam veteran generation today. It was, of course, a very large generation that served. The war lasted over 10 years, and so we're talking about 20 million Americans, half of them male Americans who were subject to being involved with the Vietnam War. So there's the poverty draft, decade of neglect, and health and economic consequences. So, these like 5 or 6 or 7 actually items of you can sort of fall them into the legacy of neglect. And obviously, as a young individual, you don't hope not to avoid these various things in your life condition, right? In terms of how you live your life and what happens to one. And what's interesting about this is really compared to World War II veterans who really came back after the war, World War II, and were really created the homeowner class, or essentially the middle class in our society. They were very successful. They were the first of their family to enter professional schools, to achieve, beyond their greatest dreams in that society, and made a major difference. And as I said, really created the middle class. Now, to see this trail or journey, we start with originally the draft, which was the conscription, the need for manpower during that war. As I said, it lasted 10 years. Many of those folks, in fact, were from lower middle class backgrounds, and that's really established in various treatments of the war and studies. It's really clear. And also not just those who were drafted, but those who enlisted. I myself enlisted as a way of getting into school, getting into college. That was the only avenue for me to get into college, was to join the military and use a GI Bill. It was very understood that was a way in. But however, for those who had that available to them, those options available, middle class and upper middle class individuals who were from privileged backgrounds, of course, college was not just available but expected, and they didn't need the military for that purpose. And so, even though there was this draft where all of a sudden they could find themselves in the military, but for others who were sort of enlisted and joined for reasons of that they were trying to better themselves, and that's what the military represented for them. Can we go back to that slide again? I'm sorry. Under draft deferments, there was a whole issue of how to escape the draft. Should you be drafted? You were not. This is an involuntary. This was conscription. You weren't intending to be in the military. There was a whole system of ways to avoid the military. This draft counseling movement, which really began on college campuses or within the environment of college students. It was really not available, not visible. It was not an option so much for working class folks and other folks in their neighborhoods. They had very little access to what one could do legally to avoid the draft, the deferments for school, or the deferments for medical reasons, or getting help with the steering away from the legal requirements if you were subjected to the draft. Thanks. One example of those who went in the military was a project called Project 100,000. And as you can see, it was where certain recruitment standards were lower. And it was really a way the military devised this as a way for a social uplift, as we would give them a way to enter President Johnson at the time, the avenues to advance themselves. And we'll do that by allowing, lowering the standards for this, quote, Project 100,000. It went off from 1966 to 71, really the peak years where there was tremendous need for manpower and to fill these infantry positions. And we had some devastating legacy of that Project 100,000. They thought they would get better or special treatment, receive, quote, special training, and get the benefits of that. However, it was really clear what occurred is that they were, in fact, A, not promoted as frequently as their peers, but B, really shifted into infantry positions. And they ended up serving in greater than their numbers should have claimed in infantry positions in Vietnam. And post Project 100,000, it turns out that in fact the results were that many became, again, beyond their numbers, unemployed, lower levels of education, but the end result was that they did poorer than their non-Project 100,000 peers in their lives. The next issue is basically the issue of African Americans and minorities who are part of the military experience in Vietnam. These numbers will show that particularly early in the war, African Americans were in fact, well, this slide, I'm sorry, this pertains to Project 100,000 again. 41% were African Americans, and how many in fact ended up in combat arms, especially during that period of time. I'm sorry, could you please go back? I'm sorry for going back and forth here. I just want to sort of give a personal rendering of that experience of African Americans. I was in the 101st Airborne Division, very elite unit, and the field leadership in the military, in the field, in combat in Vietnam, were primarily, that is, those who were medics, those who ended up walking point, those who were like fire team leaders and squad leaders, and the platoon sergeants. Tended to be African American to such a degree that I always assumed that in my unit in the 101st that African Americans were the majority of them. In fact, they weren't, but they tended to be the majority of those who were in field leadership positions. In Vietnam, in combat, for every person in the field, there were 8 who were in the rear area providing support to those in the field. And those in the field, we call ourselves grunts, were really subjected to the most sacrifices, and I think by far the greatest hardship. And really, when you're in the field, the whole issue of what rank you were broke down. It was the issue was could you read a map? Did you know how to handle yourself? Had you been through this experience? Those are the folks who were sort of the self-proclaimed and became our leaders in the field, much more so than what rank they held. And as I said, that my own experience was many of those who were in those key positions were in fact African Americans. So now we have this whole issue of what happens after the war. And again, Vietnam vets are constantly compared to the World War II vets, what happened. And so essentially that war, the issue of that war in terms of how the public perceived it, and the public, by that war, they had a hard time separating their feelings from the war from those who fought the war. That is this issue of the war from the warriors. And the negativity was really extreme. It's really hard to sort of describe unless you were there during that time of how people really felt. By then, we're talking about after I came back from the war in 1970. So these issues about who was, what people thought about them, and especially this whole idea about getting a job and what employers felt about applicants who had served in the war. In fact, they were not considered, in a better shape or an asset. They were considered really a liability. The media treated them too often as subjects of, walking time bombs, and there was drug issues, and they really captured practically every negative kind of connotation was created, sort of was expressed by these Vietnam veterans. Primarily the whole image was dominated by this idea that they had lost the war, and so how could America lose a war? And so it must have been something lacking on the part of those who fought the war. They must have either lacked courage, or they were somehow not as smart as they should have been. In fact, why were they in Vietnam in the first place? If they had any smarts, they would have avoided the draft. And of course, maybe they were just baby killers. And there were these incredibly negative images about that war because, of course, that war was so ugly in so many respects. And so the soldiers sort of carried off that image. Thanks. So the whole idea about the divisions and the feelings about the war were not just within the political class or within our leadership, but it went right to the heart of the community and the very families that veterans return to. I've counseled, and engaged thousands of Vietnam veterans over my almost 40 years, and I just can't tell you how many literally left their hometowns and became a migratory group. They clashed with their fathers who were, part of the World War II generation. In fact, that was the big comparison, the World War II generation versus the Vietnam era generation. And those strong feelings about the Vietnam veterans were lacking in so many regards. They weren't patriotic. They had lost this war. They were not respectful, to the point where the tensions and the pressure and the trauma really divided the family. They left their hometowns. They left their place where they could have had, where they had their networks, where they had their contacts, and they became isolated in these urban areas or in these rural areas where they knew no one. They did not have that same network. And remember, so many of them were from backgrounds where they didn't have those contacts to begin with. So they were the ones who could least afford being separated from the networks that they did have. So again, that whole issue of the isolation and being the disintegration from their community. Thanks. The important thing to recognize is that this population of veterans really did not get there was a lack of federal support for them. And I think part of that has to do with the fact that most of society felt that because the war was not just unpopular, but it was an ugly war, as most wars really are, that they had a hard time showing that they deserved any care. And those who should have looked after them, such as the veteran service organizations, the federal government, saw them as not just lacking, but as not deserving the care they needed. And this is really expressed in the fact that there were really no individual programs for Vietnam veterans until at least 10 years after they returned from the war. There was always, these political contests, specifically an example being in the 1977-1978 era, that the Veterans of Foreign War and the American Legion, which again were very powerful and could have influenced legislators and, in fact, D.C., they did not see Vietnam veterans as A, their constituency, and B, really deserving of what they wanted to throw their weight behind. So there was that period of time. There was a specific issue about whether they should increase pension or they should reform the GI Bill, which was shown to be clearly a second-class GI Bill compared to the World War II veteran. The GI Bill was not full tuition. It was a flat amount. It didn't cover, when I went to school, it was $325 a month. It was sort of, we used to kid ourselves, it was just enough to make me ineligible for any other financial assistance at the time. But certainly compared to World War II veterans, which really that bill covered the full freight. And it gave you book allowances, it gave you other incentives, other financial support. So the GI Bill was just clearly lacking, and yet there was very little interest on the part of the VFW and these other organizations to throw the weight behind, reforming that GI Bill to make it worth its while. Instead, they threw their weight behind a pension, which was really geared around non-service connected non-service connected income for older vets. So they chose their battles, and Vietnam veterans were not who they wanted to support. And so they blocked any development of veteran programs for those years. And that's really was a key part of why veterans got an inadequate bill, and also really not any programs. Agent Orange is one of those examples where Vietnam veterans really had to fight to get the care they needed. Agent Orange, as Amy said, it was a defoliant. It was used in Vietnam. It basically destroyed the forest, and it also created poison. It was very toxic, and Vietnam veterans were suffering from these conditions as a result of being exposed to this chemical. And when they came back, They could not get, really, it was their fight. When I say their fight, it was individual veterans and the organizations that they formed had to struggle to get recognition, and they couldn't get the VA to treat that. And a really fitting example is the head of the VA, the Secretary of the VA, Robert Nemo, in that period of time, when he was asked about this condition the veterans were complaining, said it was no worse than teenage acne, that the effects of Agent Orange was no worse than teenage acne. And if you want to think about a more humiliating statement to say to Vietnam veterans, and that that's what they were, sort of crybabies and crying out for this kind of care, and they just felt that, you know, you had to prove it to us, and so that was their struggle for justice, and we were very active with that. SWORDS as an organization was very active, as we had to be, because it was, you know, we couldn't wait around for someone to step up. Our brothers and sisters were literally dying, so we stepped up. And there was this class action suit that was filed against, not against the U.S. government, but against the chemical companies that were contracted to produce this, who made much money, much profits producing this chemical defoliant. And and this lawsuit was finally settled in 1984, literally a day before the trial was to begin. I remember that vividly. And it was settled. It was $180 million, which was, of course, obviously a tremendous sum of money, but the way it was partialed out, the conditions of the lawsuit were such that it resulted in individual veterans who could claim and show a condition, a medical problem or medical illness, received $12,800 over a 10-year period. Not $12,800 per year, but over 10 years. That's an example of how little money they had. And part of the conditions of the settlement were that certain documents were sealed. I mean, it was clearly sort of hush money on the part of the chemical companies. And again, we were left on our own to fight the VA to get compensated and treatment. And we had to struggle for that. And we were not invited to do so. It was a tremendous battle waged, you know, with the public itself. And finally, there was legislation passed in 1991. Now look at these, that's 7 years from the class action suit. But, you know, since almost 20 years from the time, in my case, 21 years from the time I got back from Vietnam, and well over 15 years from the time these conditions were happening. So veterans, for that 15 years, had no compensation and no meaningful treatment. And they were really on their own. So those are that kind of neglect certainly did them no favors in their own efforts to sort of land on their feet and go about their, you know, their civilian readjustment. And again, it wasn't until 2010 that the VA started expanding various presumptions. That is, you suffer a certain condition, you will be presumed to have been caused by Agent Orange. And that number, 260,000 claims, gives you a sense of how many veterans were affected by that. But look at all the years that had to pass while they were not affected, or then they received no compensation. Another issue was post-traumatic stress disorder, one of the invisible wounds of war. And again, veterans had to fight to establish that there was, in fact, a true condition. It wasn't invisible, it wasn't made up, it was actually a condition that affects their ability to get work, to move on with their lives. And these numbers that show, and the way PTSD was treated, again, we're talking about years later. I came back in 1970. It wasn't until the late 80s and even 1990 where it was really established to be a condition. Again, all those years have passed. And now today, 271,000 Vietnam era vets have full PTSD. And again, it was considered not a chronic condition. It was considered a condition, it'll get better, you know, take some pills, you'll be fine. It's always been a struggle to get issues of Vietnam veterans studied over a sort of a longitudinal study to show what the true conditions and what the true impact of that war has been. And for years, it was not funded. The longitudinal study was just dropped from being funded. And so there was, you know, there was no study. We had no data to show. And it wasn't until just recently where it was refunded to show today where you have these present conditions. And what's particularly telling is the fact that nearly 20% of those they studied in that in the first study have already died since that study was first incorporated. So it just shows that from 2003 until now, 20% of those they studied in that when they first examined PTSD are now deceased. That gives you a sense of the mortality issue of the neglect and the mortality issue of suffering these conditions and having very little help and very little support over the years. And of course, the fact that so many Vietnam veterans became impoverished, and becoming impoverished meant, in America, it meant, being without a steady residency and becoming homeless. And in the early 90s, when they came up with these tremendous numbers, that there were something like 300,000 homeless vets in 92, and half of them served during the Vietnam War. Astounding numbers. And it sort of shamed the nation. And still, still we had to struggle to get specific programs to address homelessness. For years after after those figures came out, HUD never even identified how many veterans were in their various programs of subsidized housing. And we had to struggle to get them to identify veterans and whether veterans were getting their fair share, given the fact that they were such a predominant part of the homeless population. Today, those numbers have been dramatically reduced, but one wonders how many, whether the reason they're reduced because veterans have literally died on the street. And it's always been a struggle to get the Veterans Administration, and specifically the hospital and the hospital directors, to pay attention to veterans on the street. They never saw them as their priority or as their responsibility. And so that's really harmed Vietnam veterans in dramatic ways. So there are the findings that veterans are older than their years. Studies show they're literally 15 years older than their chronological years, and that they're predisposed for these variety of health issues that impact their lives. It's not unusual for us at SWORDS to see veterans who have, various what we call triple diagnosed. That is, they suffer from the trauma of war called post-traumatic stress disorder. They have substance and abuse issues. They have depression, deep depression, and they have various primary health care issues. Chronic healthcare issues, diabetes, etc. And they're most frail. They're most likely to die on the street. They're most likely have a difficult time getting work or getting back on their feet. And so it's not surprising at all that as a result of that war, as a result of the neglect of the fight they had to make at every level to get the care that they should have come without questions, that they expected when they went into the service, that they expect whenever you place folks in harm's way, especially when you place folks in harm's way who are not from the privileged classes, who need more help, who need a better GI Bill. If you think about it, they needed more help than what was the average care, and they didn't get the average care, and they were deemed not worthy, and the veteran service organizations were not there to help them. There was no leadership there whatsoever, and so we have the condition we have today. And I think some of the lessons of Vietnam veterans, which they can show the current post-9/11 vets, is they can't rely on folks who will come down and help them and serve. They have to organize themselves. They have to fight for their rights, and they have to fight for justice. It's not going to be given to them. They have to fight for it. And that's really a sad state when we have a system that's supposed to help folks. That's all I have for now.
Well, thank you so much, Michael. Our final panelist is Janice Yee, Geriatric Specialist at Swords to Plowshares. Janice has worked at Swords since 2007 as both an intake coordinator and geriatric specialist in the Transitional Housing Program on Treasure Island. Janice has a master's degree in counseling and is licensed as a marriage and family therapist. Welcome, Janice. Please stand by, attendees, as we're dealing with some audio issues. Janice, if you can go ahead and unmute yourself, and then you'll be able to present. Thank you for your patience.
Oh, thank you, Megan. Can you hear me? Okay. Most of our referrals at our transitional housing program on Treasure Island in San Francisco are veterans who are coming directly from the street, shelters, cars, and so on. They have a multitude of medical, mental health, and substance abuse issues. And in most cases, these issues have gone untreated for years and years. This, plus the stress of poverty and isolation, are giving rise to an increasing number of referrals from homeless Vietnam-era veterans over 60 who are reaching out for help. In our transitional housing program, we have the capacity to house up to 71 veterans in both upstairs and downstairs units. This includes 6 beds dedicated to the frail and elderly program for veterans usually over 65 who receive help from a certified nursing assistant. So some of the medical challenges we're commonly seeing among these veterans are very serious indeed, including strokes, congestive heart failure, end-stage liver disease, diabetes, severe respiratory problems, neuropathy, prostate cancer, and both old military and non-military related injuries causing chronic pain. And many of these conditions are leaving the veterans unable to walk unassisted, and they require walkers, wheelchairs, and with our veterans over 70, we are also seeing numerous cognitive problems, cognitive impairments, including dementia. Depression is also very common among these veterans. They've suffered multiple losses through death, estrangement from their families, loss of health, the ability to work and to be physically active, loss of self-worth from being marginalized by others, for being elderly, disabled, mentally ill, for being involved in a very unpopular war. And for older veterans, depression is sometimes overlooked or misdiagnosed because it often manifests as what I call crankiness or anger rather than as actual sadness. Many also suffer from untreated PTSD, of course, due to combat or to military trauma, and that includes military sexual trauma, or from non-military trauma, or from both. They suffer from alcohol and drug dependency and have been using substances for decades, and that has been their primary way of numbing their emotions. So one of the challenges that we're finding in our transitional housing is that our veterans more and more are presenting with a combination of all of those problems, making it very challenging to have adequate housing and care for them. For example, the last 5 referrals I've received for Treasure Island were from veterans over 60 years old. 2 are in wheelchairs and 3 are using walkers and must be in downstairs units. So what we do is sort of a form of triage, giving priority to the very elderly and disabled for our frail and elderly beds, and then bringing in the other veterans into the lower units as space permits. And unfortunately, many of these veterans end up on our waiting list. And I've noticed an increasing number of phone calls from VAs outside of San Francisco County lately asking us about beds at Treasure Island with downstairs access, saying that they've heard about our frail and elderly program. So building community is another challenge for us at Treasure Island. And one of the issues is that our geriatric population ranges in age from anywhere from 55 to really 90. And so that's such a large cohort that they often have really very little in common. But speaking about the 60-plus Vietnam-era veterans, they do often have a very strong interest in military history and talking about their military experiences. Not all of them, but some of them do. And so what we're noticing is that they seem to form good connections with many of our staff at Treasure Island, and we're fortunate to have 4 Vietnam-era veterans working at Treasure Island. 3 were in combat, and I think that our 60-plus Vietnam-era combat veterans and non-combat veterans feel a connection to them. We also want to encourage trips, baseball games, books, films, music, ways to bring these veterans together and stimulate a sense of interest and also communication among them. But it is a real challenge, I will admit, to finding common ground sometimes among these veterans, and many of them have just lived alone and isolated for so long. Finding connection is sometimes really something they're not used to or comfortable with. As for access to VA services, my experience is that our older veterans are generally well served. Are generally well served by the VA, at least in San Francisco. It's not forwarding. And what we're finding is that when it comes to obtaining medical appointments and behavioral health or mental health appointments, most of our veterans are getting appointments in a fairly timely manner. Now, we may be lucky because San Francisco VA may be more responsive than other VAs, but that is, of course, the VA that I'm most familiar with. We are also encouraged by an increase in interest in gerontology, I think, at the VA, and that includes in the areas of psychiatry, physical therapy, occupational therapy, and pharmacy. And those are really specialized fields, and we really need more people who specialize in geriatrics in those fields. As far as other VA services that are needed by our older veterans, we're finding fairly good response time for medical van transport services to take our aging veterans to and from medical appointments, psychiatry appointments, and so on. And we also notice that applications for aid and attendance VA pensions are also being processed more quickly. However, there are a couple of areas which we feel could stand quite a bit of improvement, which would be setting up our veterans for neuropsych evaluations, and we understand that they're intensive and they're very costly, but we really need them increasingly so for our veterans who are having cognitive issues, and by having this neuropsych evaluation, they can get their cognitive functioning assessed, and we can better determine what sort of permanent housing needs would be appropriate for them. Also, we're finding that it takes quite a bit of time for our veterans who are disabled to order motorized wheelchairs, and as some of you may know, the manual wheelchairs are very difficult in terms of getting around, and this is often very depressing for the veterans who are confined to manual wheelchairs. So the electric wheelchairs we're noticing are really making a difference in terms of the sense of independence and the better outlook for the veterans who are disabled. Regarding housing, I think this is probably, well, this is definitely our biggest challenge, is what happens to our veterans when they've come to their 2-year stay in our transitional housing at Treasure Island, especially in the frail and elderly. For those veterans who can live independently, there are a few more options than those who cannot. And one option, of course, are the supportive housing, which would have elevator access and also social work and other help there for veterans who require that. We also have subsidized senior apartments in the Bay Area, but they usually have very long waiting lists. We also find that many veterans are happy to receive HUD-VASH vouchers in San Francisco, but that they're finding that many of the apartments that are in safe neighborhoods are very scarce. And we also feel that we need more HUD-VASH social workers who specialize in geriatrics, because they do need more assistance and they need more, appropriate housing to be safely housed. Then we're also noticing that in San Francisco, at least, there were a few really what we call very good quality senior hotels that are now changing, and they're no longer offering double occupancy rooms, making the cost for bidding for most of our veterans maybe having to pay up to $1,600 or more a month for housing in a senior hotel that's in a safe neighborhood. So the final option that is actually probably one of our best options at this time would be the state veterans homes that Amy talked about. And for those who can live independently or just need maybe some minimal care, the good news is that the state veterans homes are now being responsive to the need to house homeless veterans. So what they are doing is they're prioritizing the homeless veterans first, allowing less of a shorter turnaround time from application time to actual admission. So we're pleased to see this. But the problem, of course, is when we're talking about veterans who cannot live independently, and starting with the veterans homes again, for those who really require a memory unit because perhaps they have cognitive impairment, dementia, Alzheimer's, or they may need just some assistance from nursing staff, then the wait time at the California Veterans Homes are very, very long. It could be 2 years or even longer, and that's even with prioritizing the homeless veterans first. So that is not a real viable option for us in transitional housing because of the limited stay there. The other option would be board and care homes, and they're also very, very expensive. And most of our veterans cannot afford $2,000 plus a month in San Francisco to live in a board and care home with assistance. And even in neighboring counties, the monthly charge could be anywhere from $1,600 to $1,700 a month. So that is, not something that we can always count on for our veterans who need more assistance. And finally, there's the Community Living Center at San Francisco VA, and it's a really pleasant assisted living nursing home. However, it's only available to veterans who are service-connected. And most veterans who are there maybe for a brief time for skilled nursing, for example, have expressed the desire that this would be an optimal place for them because they're with other veterans and it's a wonderful environment. But again, that is for veterans that are service-connected only, and even with that, there's a long waiting list. So essentially, there are numerous challenges for our senior veterans, our veterans that are Vietnam-era age, and we are seeing more and more coming to us needing housing, temporary housing, emergency housing, permanent housing, and we are really concerned that we will not be able to meet those increasing needs. It's already difficult now, and so that is basically what I wanted to present to you today, a more of a day-to-day the day-to-day struggles of our veterans over 60. Thank you.
Sorry for that, everyone. We're having some audio difficulties. Thank you so much, Janice, and to all our presenters today. Now we'd like to open up a discussion with the audience. If you have any questions, please feel free to ask them via the question or chat box on the right side of your screen, and we'll do our best to go through them all. And if you've asked a question at any time during the training, we'll address those now as well. And it looks like we have a lot of questions that have come in so far. So let's start with questions regarding the Vietnam generation of veterans. First question, which I assume is for Michael. Did the World War II veteran generation eventually embrace Vietnam veterans?
Yeah, I think World War II veterans, they were very slow to even embrace their own stress. I mean, the fact that they themselves mental health had such a tremendous stigma for that generation, so they were very slow to embrace the fact that they were in fact traumatized and affected their ability to be fathers and get on with their own civilian life. But they finally came around. I think, by and large, they came around as a result of the current war, since 2003 and post 9/11, when they became we started recognizing what happens when you place people in harm's way, that there's some obligation. Vietnam veterans had this, they formed their own organization. They had this thing, never again will another generation of war veterans neglect a previous generation. But they did come around, I think, along with the rest of society. But they had their own wounds to lick, and it took them a long time to do that. I mean, I can't tell you how even those World War II vets would never really disclose what happened to them during their experience. Their families don't even know in many respects, but they did finally come around, yeah.
Okay, and the next question. Because of the high incidence of combat arms jobs being assigned to African American service members, do you see a higher incidence or higher acuity of PTSD and other trauma among African American veterans of the Vietnam generation? And that's for Michael as well.
Yeah, I think a lot. I would like to see more research in that area, but clearly, anecdotally, we've seen a lot of veterans, of course, since we've been around for as long as we have, and absolutely, African Americans have lots of different issues. I mean, there's that whole issue. Like again, during my Vietnam experience, I mean, I was in training in April, when Robert Kennedy and Martin Luther King was assassinated. We were positioned to go to places like Detroit. I was in Fayetteville with a Special Forces training group then, but there were African Americans in that unit, and not just that unit, but in the 82nd Airborne and others who were one of the early responders to some of the racial riots. Can you imagine? The stress and the trauma and the complexities of that arrangement, having been to Vietnam, then going back to sort of like keep the peace among African Americans in these very communities. But a range of things, yeah, I would say, everything, all the negativities, all those, all that misery index. I think it's even more so with that. Absolutely, I would agree.
Okay, and another question that came in regarding bad paper. Can you talk a little bit about bad paper among veterans related to the Vietnam generation, and For those that don't know what bad paper is, can you define it for them as well?
Sure. Yeah, bad paper is kind of a slang street term for an other than honorable discharge. I mean, when you're in the military, after you get out, you can receive an honorable discharge, a general discharge, which is considered under honorable conditions, and then there's this third tier administrative discharge or other than honorable. They used to call it undesirable discharge. And then there's two other levels which are punitive discharge. That is that it comes as a result of a military proceeding. One is called a dishonorable discharge, another is a bad conduct discharge. But just during the Vietnam War, there are over 530,000 veterans who received this administrative discharge, which is sort of in between. And oftentimes it was for, violations of the Uniform Code of Military Justice. It could have been, you were late for formation repeatedly, you had a bad attitude to your superior officer. Oftentimes these occurred for those who did their combat tour, came back and had stateside time before their enlistment ended, right? And so a range of things that would be hardly considered, crimes in society, but they're violations of the military code. And the military was anxious to get rid of folks. And so in many respects it was sort of like a plea bargain, if you will. You're charged with something, you could lose rank, you could forfeit pay, you could suffer, a sentence in a military confinement, or you could get out immediately or get you right out. And you'll get out with an administrative discharge. And don't worry about it, you can upgrade it somewhere down the road, which was wrong. They did not. Most veterans never got good justice or their treatment or what their true rights were. It was never quote upgraded or changed. They were denied care from the VA. They were denied health care for their war-related injuries. They got no GI Bill, and we're not talking about a small number. We're talking about 529,000 during the war, and that's your underclass. And those turn out to be a predominant number of those who are chronically homeless and unsheltered today. It can be traced back to how they were separated.
All right, thank you for that, Michael. The next question, also regarding Vietnam. What's the emotional health status of women who served in Vietnam as nurses? Some of their stories are very heart-rending. As volunteers rather than draftees, they may even perhaps have more to sort out emotionally. Do you have any comments on that, Michael?
I really agree with that. I think, for years the VA couldn't tell you how many women served, even in the nursing capacity. I don't know. We don't know. Certainly the facilities that they developed, were not geared at all toward women whatsoever, the medical facilities, the care facilities. I would say a lot of those same complexities that apply to African American vets would apply to women, certainly, and more so in certain regards. But, they couldn't even tell you how many for years after the Vietnam War.
Okay, and the next question, thanks for bearing with me, Michael, as we get through these. We have a lot of questions related to the Vietnam veteran generation. The prevalence of military sexual trauma has only recently begun to be recognized overall. Are Vietnam-era veterans now being routinely screened for this when they receive medical or mental health care through the VA? And that's that could be a question for you, Michael, or Amy, perhaps?
Could someone else answer that, perhaps?
Hi, this is Amy. They are now screening for military sexual trauma through all ages. It's relatively recently that they've started doing that. And of course, there's a lot of work to be done to address these needs. I think related to that, it also, and perhaps because of the lack of knowledge of women veterans, as Michael said, they didn't even know how many there were. But even today, women veterans of all ages are very unlikely to seek services through the VA. And it might have been because of this neglect. Of those who do seek services, they are screening them and they do have services. But again, they need to build them up a lot more. And also the community-based system of care needs to be there to be able to respond to women's needs, because whether they know it or not, women veterans are seeking care through the civilian, if you will, community-based system of care for issues related to sexual trauma. And it's important for them to know about the instances that occur in the military, that there are services out there. Another thing that is a resource for the women veterans is the vet centers, which women veterans might be more likely to go to. They're not as intimidating as a big hospital facility. They're community-based, and they are there to provide counseling for combat trauma or sexual trauma, and it doesn't matter when someone served or whether they are currently seeing the VA. There are also some services within the VA that allows for women who, or men for that matter, who have served and been exposed to sexual trauma. And I just want to emphasize, too, that this is not just a women's issue. Men are subject to sexual trauma in the military, and in fact, because there's such a higher percentage of men serving than women, the actual hard numbers of military sexual trauma survivors of men can be higher sometimes than the actual hard number of women. Of course, it is a much higher percentage of women, but we need to look at this as a problem for both men and women. So thank you.
All right, thank you, Amy. The next question, perhaps Michael, you can answer this. Veterans have to organize to fight for the resources they deserve. What are the prospects for coalition-type actions with other groups aiming for better health care, housing, and education?
This is an interesting question. I was just, talking to our colleague here about post 9/11 vet Jeff about this, but one of the advantages of having been a Vietnam veteran coming back and during that period of time was there were actually more resources that you could form your own community-based organization, whether it was a government grant, literally government grants from CETA, or funding, just the idea that there was federal, support to the local districts. There was like revenue sharing, right? So the federal government gave all the cities and urban areas much more resources. And so there's actually more money around to actually organize around healthcare, or literally to ensure that, to sort of get going. Today there's just a tremendous, just a lack of any funding just to sustain yourself as a community-based organization. But I do think there's a lot of coalition building around, ending homelessness, or around, ending the war, or and there's certainly a greater awareness now than ever from that standpoint. But boy, the resources have been just, that's what we're in. We're in the 1% versus the 99% in terms of what's available to work with. So that gets in the way.
All right, thank you, Michael. And the last question for you before we move on to mental and primary health outcomes. Can you suggest books or films that tell the story of Vietnam?
I'm sorry, I didn't hear the end of that question, please.
Can you suggest books or films that may tell the story of Vietnam? Can you recommend any?
Well, there's, it's a very profound topic, obviously, but I'm telling you, we're just barely scratching the surface of that war and the implications and the legacy of that war. I think that there was an excellent book by a gentleman named Christian Appy called Patriots, which is sort of an oral history. His collection, he sort of frames the interviews he does, but it covers the war from, all Americans and Vietnamese, what people did, how they responded, all different areas. And that's the whole thing about the war. I mean, we don't even talk about the Vietnamese, right? And literally civilians who were affected by that war, and so many aspects. But that's his attempt to cover those periods. I think he does a really nice job. There's a great book about the draft, the war and the Vietnam generation, called Chance and Circumstance. That was actually written in late 70s, 78, 79, by Lawrence Basker. That has these flow charts that really explain just how unfair the draft was. I would, those two books I think are really excellent books. In terms of film, I mean, everyone's a film critic, right? I don't know. I mean, there's been, Apocalypse Now, pretty much, I have to say, it captures a lot of the ugly insanity of that war.
Okay, thank you, Michael.
Sure.
And we can send out a list of some of Michael's recommendations for books and films after the webinar. So the next set of questions are related to primary and mental health outcomes, which I'll direct to Amy. And then after those questions, then we will pose some questions to Janice regarding housing. So Amy, first question, do Vietnam veterans with PTSD generally have a shorter than average life expectancy?
Yes, they do, sadly. I don't know if I have any numbers right here in front of me or that we presented numbers, but we do see mortality rates in the younger areas. And if you look at some of the material that we presented regarding some of the health conditions, certainly the ones related to Agent Orange, diabetes, there's several cancers. Also, with PTSD, there's higher rates of cardiovascular disease, heart attacks. So we see a lot of very, very serious physical health outcomes, and we do see a shorter life expectancy. All the more reason, I think, that it's incumbent on all of us to be aware of these issues and to make sure that the older veterans, that their providers, whether they be with the VA or whether they be with a private HMO, Kaiser, whether they be with community-based care, if they're aware of these higher risks, they can recommend or refer veterans to care that is very specific to those issues.
All right, thank you, Amy. And the next question is regarding diabetes, obesity. And it says, has the possible link between impulse control, obesity, and the DM2 secondary to such been examined?
So I took a very quick search of Google Scholar just now since I saw that question on the screen, and there appear to be a couple of studies. One is on impulse control and obesity among veterans. The author is Rosenberger, and they seem to find a connection related to depression, but in my quick review of the abstract, I'm not sure if it really looked at impulse control. But there is another study that I did see that looked at impulsivity and eating disorders, or actually it was PTSD and eating disorders. And right now I had jotted that down again off of Google Scholar, and I can't seem to find my note about it, but we will send those out. So I think, there hasn't necessarily been a lot of research. This one was 2012, PTSD and Disordered Eating. The author is Mitchell et al., and they found a frequent co-occurrence, but particularly with women with MST. So we can certainly take a quick look and see if there's more data and research out there, but probably somebody should do some.
Thanks for that, Amy. The next question is on the family configuration of older veterans that perhaps Amy and others can comment on as well. What is the domestic family configuration breakout, if they are a nuclear family versus single person, etc., for older veterans versus civilians in the same age cohort?
Well, one thing I would say is, in our experience and with the cohort that we serve, which is, those who are in need of care, who are in need of housing, our experience over the years have been that mostly it's been single veterans who either, were married and maybe had children but have become alienated from that family. And of course, part of our services, family reunification, is part of that program, and that's something that we look forward to finding for the veterans. Also, in general, I would say that, the housing facilities have grown in response to that generation. So most of the veteran housing is designed for single veterans, and I would say single male veterans. So, that's changing a little bit with the newer generations coming up. But we definitely have seen people who have been isolated, alienated from their families. Now they might have adult children who they may or may not have a relationship, but we also stress the importance of trying to reunify families, and that veterans can build a relationship with those children even if they perhaps had not been present during their childhood. And some veterans with PTSD, they feel that they're doing the family a favor by leaving, because they don't want to share, they don't want their family to suffer because of the conditions that they struggle with, which is really tragic. So that's all I have to say on that.
Thank you, Amy. I think you answered that well. I think we covered that. Next question is regarding suicide for you as well, Amy. I understand that veterans over age 50 account for roughly 2/3 of suicides. Aaron Glantz, who is a reporter for the Center for Investigative Reporting, reported that in California, records showed that World War II era veterans were killing themselves at a rate that was nearly 4 times higher than that of people the same age with no military service. Do we have any kind of breakdown of the current suicide rates by age era, focusing on Vietnam veterans, combat versus non-combat, and other factors? Do we have any hard data getting at underlying causes and predictors for veterans who complete suicide? And finally, does the number of 22 veterans per day capture all veterans or only those enrolled in the VA?
Last question first. Whoops. The number 22 is only those enrolled in the VA, so we can just assume that that's an undercount. As to the data, familiar with Aaron's work, and he is very good at collecting data. A lot of data is missing. One, whether the suicides are being counted, period, whether the coroner, in that jurisdiction notes that information. We also know that there's some areas of suicide where it is sort of reckless behavior or risk-taking behavior, but may not be deemed suicide as the cause of death. And then with the aging veterans and the higher percentages, the data that we do have is generally just VA data. So again, while we do see a higher incidence with the older veterans, that is limited. I will say, and again, I'm not a clinician, so I don't want you to take this to the bank, as they say, but generally suicide statistics are higher in young men and older men, whether or not they're veterans. And then with the exacerbation of all the issues that we talked about, the PTSD, the dementia, the stress over time, this phenomenon called loss, which is late onset stress, it's not surprising at all. Also suicide completion generally tends to be higher when a weapon is used, and veterans use weapons more often. So I'd also say that, there's a connection with moral injury, and when we talk about this, it is not a diagnosis, but it really interacts with mental health and well-being. And so when we look at loss, there's a lot of feelings of guilt, sadness. What I think during the Civil War they called it soldier's heart and nostalgia. And I don't think they can be discounted in looking at depression and leading to suicidal ideation. And And then also it might be coupled as well if people are in physical pain or in physical discomfort. And so, unfortunately, they choose suicide. And, I think when Janice was talking about the community that's built up among our veterans who live there, I think this can only help. Oops. I'm trying to read. The rates, I'm trying to read a comment here. The rates are a major undercount given that we do not know the rates of suicide attempts and completions for current military members, active reserve, and guard. So that was pointed out by one of our staff members, and again, that goes back to the data and some of the data that Erin has cobbled together. I think it is very good, but we need more data.
All right, thank you so much, Amy. Now we're going to move on to questions for Janice. So Janice, first question, what is the outlook for money to build subsidized housing and senior apartments for veterans? Since HUD-VASH vouchers aren't all that effective when there are no rentals available within the necessary monetary limits.
Well, that is exactly the challenge we're facing right now. As I mentioned before, the veterans' homes are under more pressure now to, prioritize homeless veterans. So for those veterans who can live independently, that has been probably our biggest area of improvement, where we can house veterans who are willing to go there, that is, because they have to share a bedroom, pay 50% of their income, and they also sometimes fear that once they move into the veterans' home, then that's, they're going to lose their independence, and that's where they're going to die. So sometimes it's hard to actually even have them consider the veterans' homes. But really, to be quite honest, that seems to be one of our best options right now. And then, of course, SWORDS, in conjunction with the VA, we have the supportive housing places in the city, such as the Stanford Hotel and 150 Otis Street or Veterans Academy, and those have been excellent options for our veterans who can live independently. But I'm really at a loss as to what we're going to do with those veterans who cannot live independently because of cognitive issues and or mobility, or just needing some nursing help or help with their activities of daily living. I just don't. I'm really perplexed, and if anybody has any ideas, we'd love to hear them, because unless a veteran is earning at least, and this is low, $1,700 a month, and sometimes that can be achieved through obtaining the VA pension called aid in attendance for veterans who sometimes have problems with executive functioning or other serious health issues. I really don't know what we're going to do with those veterans. HUD-VASH, as mentioned in the question, is not really a panacea for veterans, and certainly for those veterans who can't live independently, not at all. And I'm hoping at some point, and if anyone knows if HUD-VASH can be accepted at boarding care homes or assisted living, that would be extremely helpful.
Thank you, Janice. And Michael, you also wanted to provide a comment regarding HUD-VASH?
Well, the present budget, administration's budget, was not to include any new HUD-VASH, and we're hoping that we can get that to change, because that's the quote magic bullet, if you will, of finding housing. It needs to be subsidized, and the VASH does offer that subsidy. Some of the other programs, the subsidy is not a permanent subsidy; it's a partial subsidy, so it just requires, or a temporary one, I should say. So, the subsidies are really crucial for to get folks off the street.
Thank you, Michael. Next question. Housing is obviously a critical issue, and in this, the person who posed the question, in their experience, there are far less options in the rural counties surrounding San Francisco Bay Area. So what is the solution? And Janice, this can be for you and for Michael as well.
In rural counties, was that the question?
Yes.
You know, that is true. And, you know, on the one hand, for some older veterans, they might be able to afford housing in these rural areas because they're just a lot less expensive often times in the Bay Area. However, I think this might be informing why there are so many calls that are coming in these days from all different VAs from all different counties asking about our programs when we do try to, you know, prioritize the homeless in San Francisco first. You know, we want to help all veterans, but I would say that coming to San Francisco is something that they really want to think about and think about it again and again, because even though there are a lot of veteran services, the cost of housing is just really expensive. But I don't know what Michael has to say on this.
It is a very, you know, high rental market, and obviously people who are looking for housing are renters. They're not going to be owners. So the issue is where can we go to find a low, you know, market rate rent? So, you know, we've been successful just really just seeking out the entire Bay Area and trying to sort of work good relationships with these private landlords to see if they can give, you know, veterans a shot and try to incentivize it as best we can and provide and demonstrate that we could, you know, we in some cases we're do some money management or we're trying to prepay some rent, but you know it's they're renters like others, and it's a very difficult rental market right now. So we're going to areas when we can if it's outside San Francisco just to get folks a shot.
All right, thank you, Michael. And perhaps, Michael, this question can be for you as well. Does SWORDS have any plans to extend their facilities outside the Bay Area to Mendocino County, perhaps?
Well, no, we don't have a plan to extend them to Mendocino County. You know, we see ourselves as really a community-based organization. We don't see ourselves as a national one, and we support other community-based organizations. So throughout California, there are some vet-specific groups in LA and in Northern California. And San Diego, other areas like that, in Bakersfield, there's a couple of good programs. And we're happy to provide a list of other groups who are doing really good work, and to do that, we can do so. We are, you know, we have an office in Oakland. We're looking at housing opportunities there. Recently, there is a state bond measure that would allow families supportive housing built, permanent supportive housing built for families and veterans, at least to cover some of the construction costs. So that's going to create some opportunities throughout the state, and we're trying to support that at the state level. Again, you know, maybe that's part of you know, supporting other groups who work with vets around the state to create these opportunities. So we want to do that as well.
Thank you, Michael. And Amy, you also wanted to make a comment?
Yeah, I'm looking at, you know, what Janice was talking about is the, you know, the board and care, and where the veterans, you know, either because of Alzheimer's or because of physical need, you know, really need a stepped up level of staffing. And what we're seeing in our housing, and Janice and Michael, you can chime in, you know, there's much higher need, and frankly, we need more supports in terms of the way that 24-hour staff is funded, the way that medical and non-medical staff is funded. So, Michael, do you have anything to say about, you know, some of the work that you're considering or working on to try and influence the way the monies are granted and or administered to housing facilities like ourselves?
Trying to do is get the VA contracting to sort of accept you know, make it easier for the VA, in fact, to contract to a nonprofit or a provider, which can sort of clearly provide care quicker, and actually, you know, just hire their own social workers to do the support service work. And so we're trying to sort of work with the VA to make some, you know, to create some other avenues so that they can use their money more effectively. Congress has given them quite a bit of funding, and so we're trying to sort of, you know, look at it more efficient ways that they can contract out with their partners like SWORDS and others, really, so they don't feel like they have to hire all the staff. They, in fact, can work with their partners and get the housing out there quicker.
All right, thank you, Michael. We have one final question before we sign off. And this is for Janice, where can a veteran get assistance when his or her income has exceeded the income limit for subsidized housing?
That is a very good question. Actually I'm going to have to enlist the help of the others, because I'm wondering, I'm really, it's very difficult because they're in a dilemma. For one, they may actually require some support, and so their income may be high enough, say, for example, to share housing with someone, or even rent an apartment in maybe some part of the Bay Area, but they may need supportive housing. They may need more assistance. But if they don't, then usually we just expect them, I suppose, to find their own housing. And I don't know what the answer to that is, actually, because the housing is still forbidding. At least, the cost of housing in the Bay Area is still forbidding. So even if a veteran is, say, over the cap at Treasure Island, which is around $2,400 a month, I believe, they may still, in fact, not have enough money to rent their own apartment. So that is a really good question. I'm not actually sure at this point what to say.
Okay, thank you, Janice. And perhaps that's something that we can follow up on as well. So that concludes this webinar. Thank you to our presenters and to you, our listeners. Please note that each of you will receive an email shortly asking you to complete a brief survey to evaluate this presentation. Your feedback is very important to us and is greatly appreciated. And those of you seeking continuing education units or certificates of completion will need to complete this information in order to receive credit. And also, we will send you copies of the PowerPoint, and the webinar will be archived on our YouTube channel within the next few business days, and we'll send you a link to the presentation once it's live. So thank you again to our presenters, and thank you to our listeners for your time. This concludes our online training, and you may now disconnect.